Moving on to the next speaker, I'd like to introduce Dr. Lei Zhao. She's in the GI and liver group at the Brigham and Women's Hospital and is going to talk about fatty liver disease.
So again, my name is Lei Zhao. I'm a pathologist at Brigham and Women. It's my great pleasure and honor to be included in this course and to talk about some of my favorite topics. So I will start with steatotic liver disease, and I will return with a few more topics later during the slide seminar. So this will be a case-based discussion. We'll use 3 cases to discuss the most common clinical indications for liver biopsy in the setting of steatotic liver disease. But before we do that, we'll discuss some more recent updates on the nomenclature and therapy for steatotic liver disease. So many of you probably already learned about this new set of nomenclature recommended by this paper published in Journal of Hepatology last year. So this paper recommends to use steatotic liver disease, SLD, to replace the old term fatty liver disease. And also it recommends to use the new terms metabolic dysfunction associated steatotic liver disease, MASLD, and metabolic dysfunction associated steatohepatitis, MASH, to replace the old terms NAFLD and the NASH. I personally like these updates very much. First of all, these new terms are less stigmatizing by they remove the word alcohol and the fat in a diagnosis. At the same time, these diagnoses become more straightforward and link the etiology directly with the disease. Also, this new system created 2 new subgroups, the subgroup of MET-ALD, to include those patients have both metabolic risk factor and also increased alcohol intake. Historically, these patients have been excluded from research studies, from clinical trials for NAFLD, given their increased alcohol intake. Now, with the creation of this new subgroup, finally, these diseases can be further characterized. And then another new subgroup would be the SLD with specific etiology. This subgroup is to include those patients who do not have significant metabolic risk factor and do not have increased alcohol intake. Their steatotic liver disease would be secondary to drug-induced liver toxicity or genetic alterations, genetic disease. And historically, previously, this group of disease was loosely grouped under the term NAFLD. But to distinguish them from the primary NAFLD, from the NAFLD related to metabolic syndrome, we will call them NAFLD with secondary causes, but these terms are still very confusing. So this new subgroup really brings some more clarity to this group of disease. And the last thing I want to point out here is this paper is based on the Delphi study, which is more like a consensus study done by a large group of panelists. So there's no new scientific data emerged from this paper. And the paper states that more than 98% of patients with NAFLD diagnosis should fulfill the diagnosis criteria for MASLD. In other words, most of the existing research study, including pathology study done under the topic of NAFLD, their conclusions should still be valid using these new terminology. The other big news recently is the recent FDA conditional approval of this new drug, resmetirom, to treat NASH with liver fibrosis. So this is the first USDA approval for a drug to treat obesity-related liver disease. And notice, to qualify for the treatment, patient must have a diagnosis of NASH with stage 2 or 3 fibrosis. So with these updates, we're gonna start our cases. The first case is a 39-year-old man had psoriasis and a psoriatic arthritis, obesity, prediabetes, hypertension, and established clinical diagnosis of MASLD. His current liver function tests, including ALT 114, AST 54, alkaline phosphatase 146, These numbers are slightly increased from the numbers 8 months ago. And he had a recent weight gain of 30 pounds. So let's pause here and ask, why do we biopsy this patient? This patient already had a clinical diagnosis of NAFLD. We'll discuss how this clinical diagnosis is made in our next case. But if someone already had a clinical diagnosis of NAFLD, why do we biopsy them? As you all aware that NAFLD or MASLD is an umbrella term, which includes two conditions. One is simple steatosis, the other is steatohepatitis. And most people believe that only steatohepatitis increases the risk of fibrosis and cirrhosis. So it's clinically important to distinguish the two conditions. And this distinction cannot be done without the liver biopsy. And also, once a steatohepatitis diagnosis is established, we need to grade the activity and the stage of the fibrosis. So these liver biopsy is very important for risk stratification and also clinical management, especially with the recent approval of the new drug. So the patient underwent the liver biopsy. At low power, you can already appreciate some steatosis. In addition to steatosis, you also notice a few foci of lobular inflammation and the rare apoptotic cells, the acidophil body highlighted by the yellow pointer. And there are multiple balloon hepatocytes in this field. There are some more examples of hepatocellular ballooning degeneration. On trichrome, there is no evidence of cirrhosis, but there is some expansion of the portal tract. And there's also centrilobular and the sinusoidal fibrosis. Here, around the portal tracts, you start to see thin fibrous septae extending into the periportal parenchyma. And here is another field of the periportal fibrosis. So the diagnosis for this case is very straightforward. It's steatohepatitis, grade 2 of 3 with centrilobular and the periportal fibrosis, stage 2 out of 4. We use a Brown system for grading and staging at Brigham. But the reason I picked this case is to discuss 3 important questions. First of all, what are the common histologic features we can see in MASLD? And also, what are the unusual findings that are atypical, not typical for MASLD diagnosis, and that should raise a suspicion for alternative diagnosis? And also, how do we distinguish steatosis from steatohepatitis? And lastly, we'll go over the scoring and staging system for MASLD. So let's start with the common histologic findings in MASH. Macrovesicular steatosis refers to those large lipid vacuoles that push the nuclei of the hepatocytes to the periphery of the cell. And notice the vacuoles can be small, and there might be multiple lipid droplets in the same cell, but eventually those small droplets would coalesce into bigger droplets. And this is different from the true microvesicular steatosis. The true microvesicular steatosis refers to those tiny to small lipid vacuoles in the hepatocytes, but the nuclei stay in the center of the cell. And microvesicular steatosis are usually secondary to severe mitochondrial dysfunction. And patients tend to be very sick clinically. And this, again, the microvesicular steatosis tend to involve every single hepatocyte in the biopsy. But on H&E, microvesicular steatosis can be difficult to diagnose because it shares some overlapping feature with ballooning degeneration or even glycogenosis. But the real ballooning degeneration tend to be scattered around, whereas microvesicular steatosis tend to be very diffuse. And glycogenosis would be positive for PAS, whereas a microvesicular steatosis is not positive for PAS. So the steatosis tend to accentuate from the central veins or the zone 3 area in adult patients. But in adult patients, if you see diffuse pattern of steatosis, that usually raises the possibility of a drug-induced steatosis. But the disease pattern is actually very different in pediatric population, and we will elaborate that in a later of the talk. Ballooning degeneration refers to enlarged hepatocytes with irregular membrane and those granular deposits in the cytoplasm, and those are the collapsed cytoskeleton. And sometimes these deposits can be very prominent, staining hypereosinophilic and very dense and ropey. We call that Mallory Dank bodies. These Mallory Dank bodies would be positive for CK8, CK18, and the ubiquitin. But clinically, we don't use immunostain to diagnose Mallory body or ballooning degeneration. Acidophil bodies can be present in mast cell, but it's not specific or sensitive. Lobular inflammation is required for steatohepatitis. And these infiltrates tend to be mixed infiltrates and usually around those injured hepatocytes. Megamitochondria refers to those pink eosinophilic globules in the cytoplasm. They're presumably caused by oxidative stress, but this by itself is also non-specific. You may also see lipogranulomas. Those are small, poorly formed granulomas, often associated with a lipid vacuole, lipid droplet. And you may also see certain degree of portal inflammation, but they are usually very mild. If you see dense portal inflammation, that should raise the possibility of superimposed chronic hepatitis. And the fibrosis pattern in mast cell, in MASH is also very unique. They usually start around the centrilobular zone, around the sinusoids. And with time, as cirrhosis develop, they often start as micronodular cirrhosis because of the extensive central to portal, and the portal to portal linkage. But eventually, some of the small nodules will coalesce into larger nodules. So those are the features that are common for mast cell. Now let's look at a few features that are uncommon for mast cell, and then the presence of these features should raise the possibility of alternative diagnosis. First of all, pure or predominant microvesicular steatosis is not common for mast cell. And when you see this, you should consider all these differential diagnoses listed here. Dense portal inflammation in adults, as we mentioned, raise the possibility of superimposed chronic hepatitis. But now a few more words on pediatric MASH or pediatric NASH. The pediatric patients have very different morphologic spectrum. They tend to have more portal inflammation, and the steatosis is often most heavy in zone 1 around the portal tracts. Ballooning can be minimal, and fibrosis often start around the portal areas as well. Also, the prominent hepatocyte ballooning with minimal steatosis is unusual for mast cell. We need to rule out amiodarone toxicity. Also, for people who have alcohol overuse, if they stop drinking for more than 2 weeks, the steatosis would disappear, but ballooning degeneration will remain for a long time. If you see diffuse ballooning-like degeneration, then it's possible we're mistaken glycogenosis or microvesicular steatosis as ballooning degeneration. Ballooned hepatocytes adjacent to portal tracts are usually secondary to chronic cholestasis. Another term to describe those cells would be feathery degeneration. Large epithelioid and necrotizing granulomas are not typical for mast cell. Significant plasma cell infiltrates really raise the possibility of autoimmune hepatitis. Cholestatic features are not typical for mast cell, except alcohol-related hepatitis. For alcohol-related hepatitis, you may see Mallory Dank bodies surrounded by neutrophils. This phenomenon is called sphygmomatosis. You may see prominent cholestasis, centrilobular predominant microvesicular steatosis or foamy change, and sclerosing hyaline necrosis. All these features are more frequently seen in alcohol patients with alcohol overuse, but there's a lot of overlap between MASH and alcohol-associated hepatitis. So the next quick question is, how do you distinguish steatosis versus steatohepatitis? I think to diagnose a steatohepatitis, In addition to at least 5% of steatosis, we also have to see ballooning degeneration and lobular inflammation. So that's the key difference, the ballooning degeneration and the lobular inflammation. So now let's go over some of the scoring system. The Elizabeth-Brunt system was developed by Dr. Brunt in 1980s, and this is a foundation of all other scoring systems. And we still use it at Brigham, and I know many other academic institutions also use Brunt system still. The next scoring system, Nash-CRN NAS score, is really developed for research purpose, but the European SAF score is developed for the clinical diagnosis. So we'll have a quick look at all these systems. So the Brunt system scored the activity of steatohepatitis based on 4 clinical histologic features: steatosis, ballooning degeneration, lobular inflammation, and portal inflammation. They score these features from mild, grade 1, to severe, grade 3. The Nash-CRN NAS score have very similar system. They score the activity based on 3 features: steatosis, lobular inflammation, and the ballooning, and you come up with a numerical score from 0 to 8. But it's worth noticing here that this system is really developed for research purpose and the clinical trials. The score is not useful to distinguish steatosis versus steatohepatitis. In other words, we should not use it for clinical diagnosis. The improvement of European SAF score is, first of all, this system recognized that although some degree of steatosis is necessary to make a diagnosis of steatohepatitis, but the degree of steatosis is really not related to clinical outcome. So they pay less attention on the degree of steatosis, and they developed this algorithm that if you follow this algorithm, you will achieve a score, and this score is useful to distinguish steatosis and steatohepatitis. But this system is not widely used in US. The staging system is mostly developed based on the staging system proposed by Dr. Brunt. And there's some slight modification recently. So this is what we're using at Brigham, where the stage 1 refers to sinusoidal or portal and periportal fibrosis, and stage 2 refers to periportal and portal fibrosis and sinusoidal fibrosis. And stage 3 would be bridging fibrosis, and stage 4 is cirrhosis. So to summarize case 1, using this case, we review the features that are typical and for MASLD and the features that are not typical for MASLD. We review all the scoring systems. We also learned how to distinguish steatosis from steatohepatitis. So now moving on to the next case. This is a 56-year-old woman. She's a new patient with mild right upper quadrant discomfort for 2 weeks. Her medical history is significant for dyslipidemia and hypertension. Her labs are shown here, AST 49, ALT 83. Other numbers are unremarkable. So first of all, let's ask, what should we do next clinically? There are some options. A is lifestyle modification to try to lose some weight and repeat liver tests in 6 months. B is liver biopsy. C is imaging to evaluate degree of fibrosis. And D is to do more tests to rule out other chronic liver disease. So before I answer the question, let's just review how clinical diagnosis of NAFLD is made. So this is what the clinicians and the hepatologists at Brigham do. So they first need to rule out history of other chronic liver disease, such as viral hepatitis, alcohol abuse, hemochromatosis. And then the patients have to meet 3 out of the 5 criteria for metabolic syndrome. And then hepatic steatosis on imaging or liver biopsy. So I think now it becomes clear the next step for this patient is really to do more tests to rule out other chronic liver disease. So she had more laboratory tests, which are all listed here. Viral hepatitis panel is negative, but she does have a mildly elevated ANA 1 to 80, and some abnormal iron studies a high ferritin, and a low total iron binding capacity. And given the mildly elevated ANA and abnormal iron study, she underwent a liver biopsy. So at low power, the liver shows some steatosis, and you can even see some ballooning degeneration at low power. But the portal tracts are free of inflammation. There's no interface activity. An iron stain shows some patchy iron deposits in hepatocytes and in sinusoidal Kupffer cells. So the diagnosis for this case is also pretty straightforward. This is a steatohepatitis, grade 1, stage 1. There's iron deposition in hepatocytes and Kupffer cells, grade 1 or 2 out of 4, and there's no evidence of autoimmune hepatitis. So the reason I picked this case is you probably have noticed that the biopsy, liver biopsy for abnormal iron study and also for elevated ANA or other autoimmune markers has become a very common indication in the setting of SLD, steatotic liver disease. So let's first talk about what do we need to learn about abnormal iron studies in metabolic syndrome. Many studies have shown that people may have abnormal, especially elevated ferritin due to metabolic syndrome. But those ferritin levels tend to fluctuate from time to one test to another, whereas in people with hereditary hemochromatosis, their ferritin level usually progressively increase over time. And also total body iron level is normal in people with metabolic syndrome, whereas they are elevated in people with hemochromatosis. And for pathologists, what we care most is probably the staining pattern for iron on liver biopsy. So we all know that for people with hemochromatosis, the iron start to deposit around the portal tracts, and they often show this portal to lobular gradient as shown in this example. But for metabolic syndrome, the iron deposition appear to be more heterogeneous. You may see them in Kupffer cells only, or hepatocytes only, or most of the time it's a mixed feature in both hepatocytes and Kupffer cells. So here is an article that really looked into the iron deposit, like a staining pattern in people with insulin resistance. So they observed that the iron deposits can be present around the portal tracts, but the distribution of periportal iron tend to be heterogeneous and patchy. You can also see iron deposits in Kupffer cells and the hepatocytes around them, which is similar to what we saw in our case. I think one thing worth knowing is the periportal iron is really not as 100% specific for hemochromatosis. It really just indicates intestinal iron hyperabsorption. And you can see this in many other conditions, in addition to hemochromatosis. And the sinusoidal iron level usually correlates with the inflammatory state. In other words, if there's more inflammation, you may see more sinusoidal iron. And what will clinicians do with our pathology report? They don't really care too much about the pattern of iron deposits. We really pay more attention on the amount of iron in the biopsy. If you report significant amount of iron, grade 3 or 4, they will definitely do more tests, order genetic testing and a dry weight, and also consider phlebotomy. There are a few scoring systems for iron. This is one of the most commonly used system here for your reference. But just be aware, different institutions may use different scoring system. To summarize this case, we talked about abnormal iron studies, which is common for MASLD, but this might be an indication for liver biopsy. Stainable iron can be seen in both hepatocytes and Kupffer cells in the setting of MASLD, but the quantity of the stainable iron is more important for clinical management. The other question, the common indication for liver biopsy for people undergoing workup for MASLD is to rule out autoimmune hepatitis, like what we saw in our case. Mild to moderate amount of portal inflammation in MASH is acceptable. And usually the amount of portal inflammation should correlate well with the amount of inflammation in the liver lobules. And up to 30% of mast cell patients may have positive ANA, and 5% of them even have positive SMA. To establish a diagnosis of autoimmune hepatitis, you really need to see unequivocal interface activity or lobular hepatitis with necrosis. So that concludes case 2. Let's move on to case 3. This is an 8-year-old boy. The parents noticed a regression in his behavior, and he was found to have enlarged liver as incidental finding, subsequently found to have elevated liver tests. He underwent a liver biopsy, which showed diffuse steatosis on the liver biopsy. And there are also some mild degree of portal inflammation, mild degree of lobular inflammation, and some ballooning degeneration. And here around the portal tracts, you see lots of significant steatosis and multiple balloon hepatocytes, which is kind of what expected for pediatric MASH. And there's a little bit portal inflammation and portal fibrosis. Everything we see here is somewhat expected for pediatric patient. And here's more example of balloon hepatocytes and one glycogenated nucleus. So again, the diagnosis seems to be straightforward. This is a steatohepatitis with periportal and the pericellular fibrosis. However, the patient subsequently was found to have low ceruloplasmin and elevated urinary copper. And the genetic testing revealed mutation in the ATP7B gene. So this patient had Wilson's disease, not MASH. So here I listed some facts about Wilson's disease. I won't go over them one by one, but just to highlight that hepatic steatosis is the earliest, often the earliest histologic feature in Wilson's disease. And this probably reflects the mitochondrial dysfunction caused by copper toxicity. And the Rudman stain, the special stain for copper, can be negative in early stage of the disease. It has low sensitivity, but even in late stage disease, due to sampling error, you may still have false negativity. So copper dry weight is really the gold standard for diagnosing Wilson's disease. Wilson's disease have many different histologic presentations, as we saw one example in the earlier talk. But for children, when you see steatosis, diffuse steatosis in a child without metabolic risk factors, that raise the suspicion for Wilson's disease. And for adult patients, often is severe inflammation mimicking chronic hepatitis, viral hepatitis, autoimmune hepatitis. So let's see some example. Here is another liver with steatosis and the ballooning degeneration. This Wilson's disease have some lobular inflammation. This example has severe portal inflammation with lots of plasma cell, really mimicking chronic autoimmune hepatitis. When fibrosis develops, they may even be pericellular, sinusoidal and pericellular. And this is an example of satelitosis in Wilson's disease, where you see neutrophils surrounding those densely eosinophilic hepatocytes. This is another example with a heavy, very dense chronic hepatitis pattern of injury in someone with Wilson's disease. I think use this example, I really just want to emphasize that steatotic change is a very non-specific finding of liver injury. So in addition to metabolic syndrome, there are many other diseases can produce steatosis and steatotic-like injury. And I listed all differential diagnosis here for your reference. And lean MASH and lean mast cell do exist, but in general, if you have a steatotic liver biopsy without significant metabolic risk factor, this would really warrant a more comprehensive clinical and the pathology correlation. Steatosis and the steatohepatitis-like change can also be seen in liver masses. We are pretty familiar with steatohepatitic pattern of hepatocellular carcinoma. But most people are not aware that you can also see steatohepatitis-like changes in hepatocellular adenoma and FNH, as reported in these articles. Another close mimicker of balloon hepatocytes would be pacoma cells, the spider cells in pacomas, that could closely mimic ballooning degeneration of hepatocytes. So to summarize this case, steatosis and the steatohepatitis injury pattern can be seen in many other conditions other than metabolic syndrome. So clinical correlation is crucial. In steatosis and steatohepatitis-like changes can be seen in liver mass lesions, such as HCC, adenoma, and FNH. So thank you for your attention.